Clinical Assessment and Evaluation of Anxiety Disorders by Nathaniel Markert. What is an anxiety disorder? Hollyfield, Mackey, and Davidson describe anxiety disorders as a group of psychological problems that affect behavior, thoughts, feelings, and physical sensations. Their key features include excessive anxiety, fear, worry, and avoidance. Furthermore, the researchers found that anxiety disorders can be associated with stressful early life experiences. It's important to note that not all people with early life stress develop anxiety disorders. According to a recent study by Gauthier, a Canadian researcher, 24.9% of the Canadian population will be affected by an anxiety disorder during their lifetime. Additionally, she found that women are more likely than men to experience anxiety disorders. According to the Mental Health Supplement of 1990 Ontario Health Survey, 9% of men and 16% of women in Ontario experience anxiety during the survey. Few types of anxiety disorders. In this presentation, I will cover panic disorder, social anxiety, specific phobias, and obsessive-compulsive disorders. The first anxiety disorder I will discuss is called the panic disorder. So what is the panic disorder? Gauthier describes a panic disorder as the occurrence of recurrent unexpected panic attacks, most frequently called panic attacks. These attacks come out of thin air in places where there is nothing to fear. So what does it look like or feel like? Although generally lasting only a few minutes, panic attacks can cause a person to feel like he or she is having a heart attack, dying, or even going crazy. Many people describe the sensation as an out-of-body experience, where they have little or no control of what is happening. The National Institute of Mental Health quoted one individual accounting experience of a panic attack. One day, without any warning or reason, I felt terrible anxiety came crashing down on me. I felt like I couldn't get enough air no matter how hard I breathed. My heart was pounding out of my chest, and I thought I might die. I was sweating. I felt dizzy. I felt like I had no control over the feelings, and I thought I was drowning, and I couldn't think straight. Current treatments and approaches for panic disorders. The first, cognitive behavior therapy, teaches you different ways of thinking, behaving, and reacting to the feelings that come on with a panic attack. The attacks can begin to disappear once you learn differently and react differently to the physical sensations of anxiety and fear that occur during the panic attack. Medications are also used in unison or alone to help manage these panic attacks. I will dive deeper into CBT, or cognitive behavior therapy, and medications later on the presentation. What is social anxiety? Key element of social phobia is extreme anxiety about being judged by others or behaving in a way that might cause embarrassment or ridicule, as said by Gauthier. So what does this look like? Some social anxiety can be strong enough to induce symptoms like heart palpitations, faintness, shortness of breath, and even profuse sweating. How does this affect the life of an individual? Social anxiety can have a profound effect on the quality of life. This can trickle down, and effects can be seen in an individual's social, emotional, or work life. Fisher, Bex, Coucher, and Massia-Warner found that social anxiety is linked to other mental disorders. This is including, but not limited to, the other anxiety disorders I'm discussing today, mood disorders, and even substance abuse. The current treatments and approaches for social anxiety are cognitive behavioral therapy, like I discussed earlier. The next, cognitive restructuring. This is defined by Singh and Hope, is the process by which an individual identifies and challenges irrational or maladaptive thoughts, including beliefs, assumptions, and expectations, and replaces them with more rational, realistic, and adaptive thoughts. Furthermore, it is used to interrupt the cycle of negative thoughts, anxiety, and behavioral avoidance. Quick example. Imagine you're waking up on your birthday. What do most of us do? We go on Facebook, check to see who posted on our wall. You expect to see all your friends have commented on your wall, but your best friend didn't. A person with this type of anxiety may formulate questions like, why didn't they post, or why didn't they care enough to post? A cognitive restructuring process should hopefully change those thoughts to, well, maybe they haven't gone on Facebook today, so they didn't get notified that it was my birthday. But wait, I think they might have said happy birthday to me yesterday, even though that was a pre-happy birthday, so I guess it's not a big deal. The end goal here is to change negative to positive in regards to belief assumptions and expectations. Therapeutic exposure and role plays in video I will discuss later. Specific phobia disorders. Most of us are familiar with several of these items that are on this list, perhaps arachnophobia, the fear of spiders, claustrophobia, being scared of enclosed spaces. This image shows a few of the more common ones, but I'll dive into it in a few moments. So what is a phobia disorder? Harvard Medical School classifies a phobia as a persistent, excessive, unrealistic fear of an object, person, animal, activity, or situation. It is an anxiety disorder. A person either tries to avoid the thing that triggers the fear or endures it with great anxiety and distress. Gauthier says that this anxiety disorder is marked by two components: intense anxiety when exposed to some sort of specific phobic stimulus or situation, and persistent fear of the stimulus between the episodes of exposure. Skillful avoidance of the phobia, stimulus, or situation can allow individuals to function for years until circumstances force them to confront the object of their phobia. So what does this really mean? Examples: can you imagine someone throwing a spider on you? Are you that afraid? How scared do you get at the top of a building? Enough to never go in a building? So what does this look like for an individual? Flatt and King describe the three major response systems that are frequently evident in phobic reactions. The first, cognitive, thoughts of being scared or self-declaratory thoughts. The second, physiological. This includes items like increased heart rate or butterflies in your stomach. The third, overt behavioral responses. This includes rigid posture, perhaps even thumb-sucking in children, crying, and avoidance. Specific phobias are one of the most prevalent childhood anxiety disorders. The researchers suggest that phobias in children, such as animals or situational phobias, lead to significant impairments in peer relationships, social and academic competence. Hence, it is imperative to treat phobias within children and adolescents early to avoid serious ingrained symptoms later in life. Assessments in phobia. Diagnostic evaluations and self-reports are frequently used to assess and evaluate those with anxiety disorders. King, Morris, Olendick, and Gallone describe one of the most frequently used tools, the Anxiety Disorder Interview Schedule. This is a structured interview designed to assess for current episodes of anxiety disorders and had to permit differential diagnosis among anxiety disorders. According to the DSM-IV criteria, these items are on a scale of 0 to 8 in relation to fear and how much it affects their lives. Behavioral avoidance tests, or BATs, and DOAs make a person face their fears. For example, if a person is afraid of dogs, the test will slowly introduce the dog at a distance, and maybe even the dog will walk closer on a leash towards the individual, and that might even result in the phobic individual touching the dog. This is usually completed in a controlled environment and in a laboratory setting. Treatment of phobia disorders. In vivo or exposure treatments are based on the principle that the clients are best treated by exposure to the very thing they want to avoid. The stimulus that invokes intense fear, anxiety, or other painful emotions. The goal of this is to expose the person long enough so that their fear is realized and the negative result they expect is not the realistic outcome. Behavioral family interventions are usually used in younger children. For example, King, Morris, Olendick, and Gallone use the term co-therapist to describe the role that must be played by the parents. Though the therapist is the person who is primarily in charge of the procedures, the parent still plays a crucial role. Medication is also used in this scenario, but I will dive into that deeper later on. OCD, or obsessive-compulsive disorder. The essential feature here is either obsessing or compulsing. Obsessions are ideas, thoughts, images, or impulses that recur and persist. These are experienced as senseless, intrusive, unwanted, or repugnant phenomena that invade conscious and produce anxiety despite attempts to suppress or ignore. Gauthier, 1999. What happens to an individual if they try to resist the urge to fight it? When the individual attempts to resist the compulsion, he or she feels a mounting sense of tension that is relieved immediately by yielding to the compulsion. How common is OCD in the population? According to Rapp, Bergman, Piamente, and McGuire, OCD affects about 1 to 2% of the overall population. Gauthier found that the typical obsessions include contamination, doubting, aggressive impulsing. Compulsions are repetitive, deliberate, purposeful, and goal-directed. They're performed according to certain rules or in a stereotyped fashion. Two common assessment tools for OCD are Anxiety Disorder Interview Schedule, as I spoke about earlier, and the Yale Obsessive Compulsive Scale. This scale is a symptom checklist and severity scale to consecutively rate obsessions and compulsions. A symptom checklist includes 54 common obsessions and compulsive behaviors, which are grouped according to thematic content or behavioral expression. Symptoms are rated from 0 to 4 across 5 dimensions. 1. Time and frequency. 2. Interference. 3. Distress. 4. Resistance. And 5. Degree of control. Here's a quick chart showing the cyclical nature of OCD. Treating OCD. Cognitive behavioral therapy is the most common, specifically ERP. The ERP referring to exposing yourself to the thoughts, images, objects, or situations that make you anxious or start your obsession. Response prevention part of ERP refers to the making a choice not to do a compulsive behavior. Medication is also used. Cognitive behavioral therapy, as I quote from Rector, Mann, and Lerman, it is different from historical approaches to psychotherapy, such as the psychoanalytical approach, where a therapist looks for unconscious meaning behind the behaviors and then formulates a diagnosis. Instead, CBT is a problem-focused and action-oriented therapy. Medication. Benzodiazepines are one of the most common medications here. They're primarily used for individuals who have suboptimal responses to antidepressants, and also they're frequently used for short-term effects. This can have bad effects, as this is appealing to the patient but not always desirable. They can be reinforced by pill taking, and this can become a negative effect on them. Antidepressants are most frequently used to treat anxiety disorders. Among the most common drugs are Zoloft, Lexapro, and Prozac. Farrak et al. 2012 found that approximately 30 to 50% of patients experience more mild and transient side effects, most commonly nausea, diarrhea, headache, and insomnia, jitteriness, or restlessness. These are poor symptoms, but still better than fighting off the illness. So what are the ethical, cultural, and societal issues we face with these tests? In many treatments and assessments mentioned earlier, a massive ethical responsibility is placed upon the professional administering those treatments and assessments. For example, in any in vivo type treatment, the participant is exposed to the anxiety he or she is trying to combat. Possible negative outcomes include worsening symptoms, refusal to seek further treatment, and the list continues. Therefore, treatment must be provided by a licensed and seasoned professional in order to minimize the potential negative side effects. In treatments that involve medical interventions, many potential dangers exist if not executed properly. Besides the potential side effects from the specific medications administered, misdiagnosis of symptoms could lead to the recommendation or administration of incorrect medicines. For this reason, seeking professional help is crucial. Any attempt to self-medicate or otherwise use medicine without consulting a professional can have poor and in some cases deadly consequences. Finally, I quote Incel from the National Institute of Mental Health. The economic costs of mental illness have never been easy to pin down. The costs of mental health care can be estimated in a way like most other healthcare costs. The Agency for Healthcare Research and Quality cites a cost of $57.5 billion in 2006 for mental health care in the U.S., equivalent to the cost of cancer. But unlike cancer, much of the economic burden of mental illness is not in the cost of care, but the loss of income due to unemployment, expenses for social support, and the range of indirect costs due to chronic disability that begin early in life. So in summary, gave you a view of anxiety disorders, how they're assessed, and how they're treated, and the consequences of mistreatment and misdiagnosis of these disorders. I thank you very much for taking the time to listen to this presentation. I hope it has helped you understand not only what anxiety disorders are, but also how they affect those that suffer from. And if you're going to take one thing away from this, it is that you must remain in the hands of a certified professional if you're trying to combat one of these diseases. Without doing so, can have harmful effect not only to yourself, but those around you. Thank you very much. I hope you enjoyed the presentation.